morning, and welcome to an episode of the Heart of Dentistry podcast. I'm Brandy Hooker Evans, and this is my dear friend, Jamie Marbeau Nichols. And today we have a treat in store for you. Jamie, I can't even stand myself. I'm so excited. What's happening today?
Well, I'm excited too, because as our title and our journey of why we're doing this podcast, taking the ache and putting the heart back into dentistry, this goes right up following that exact theme, does it not?
Perfect.
So I am so excited. I have goosebumps. In fact, I don't know why, because I think it's just because I love and I respect our guest today so much with her knowledge and her heart. Dilaine Gloege has been a friend of mine for a while, and we are lucky enough, both Brandy and I, to work with her. And Dilaine has this amazing, crazy amount of knowledge about medical and dental coding and documentation. And she works with practices all over the country. And she does seminars and she does workshops on helping people do the best they can, not only to get the most out of their insurance, their third-party contributors, but also to keep them hopefully ever out of jail or having fines and lawsuits. So welcome, Dilaine.
Thank you so much, Jamie and Brandy. I am super excited to spend a few minutes with both of you today, and you guys are amazing, and I love the title of your podcast. Oh my goodness.
Right? We love it too. Thank you for that. So today we were talking about what we think, and I doubt we're not going to want to have you back on again, because let me tell you, this will just bring up something else that we need to talk about. And I'm sure that our viewers will request more time with you, whether it's personally or back on as one of our guest speakers. But we wanted to just go over the topic we are going to talk about today is documentation and or lack of good documentation, right? So we were chatting a little bit, the three of us, before we started recording this. And one of the things that we were talking about that I think would be of interest, right, to start off, is you've been doing this for 36 years, and it has changed the whole canvas of what is needed in our documentation has really changed lately, hasn't it?
Absolutely. So, used to our documentation, our clinical note consisted of 2 or 3 lines, and that was it. We didn't have to prove why we were doing something and why was a procedure required. There's so much more to the clinical note now than ever before. So, what is a clinical note? What does it do? First of all, it's a legal document, and it's the only documentation we have to tell the story. So in dentistry, when we think about the clinical note, that's what it is. It tells the story of each patient encounter. So we have to up our storytelling game. And what's missing is that specificity in our clinical note. And that's
Like, can you give some examples of that? Like, let's talk about, since, Brandy and I are both dental hygienists by degree, why don't we talk about something and what that looks like maybe in the hygiene arena? I know we could talk about all kinds of stuff, but why don't you talk about something that's in the hygiene arena that's specific to what you're talking about?
Absolutely. So if we take a moment to consider perio maintenance procedure, in our CDT code language, the nomenclature and the descriptor, it describes what is involved in that procedure. And if we really take a step back and read those descriptors and that descriptor from 4910, we'll find out that that procedure includes a prophylaxis. And oftentimes, I don't see any mention of scaling and polishing. Sometimes I do, but oftentimes I don't. And it also includes site-specific scaling and root planing where indicated. So I'll see perio maintenance or periodontal maintenance, and I won't see the details of it. You've got to tell me more. Tell me what teeth you performed site-specific scaling and root cleaning on. What sites? I need to know about it. I need to know what you saw, when you were doing that procedure. And that's the story. Anybody reading that encounter should know exactly what was done and why, and what was the patient's condition. You have to describe that to me.
And so let's make sure we get really granular here. You're not suggesting that they code an 1110, an adult prophy, nor do they yes, I just want to let me tell you, they get this is a big confusion thing. And so nor are you recommending that they would code a scaling and root planing in 1 to 3 teeth or 4 or more. Those don't come together. That's not what you're saying. What you're saying is that under this code, we have to document that we did what we would have done in a prophy, which is the scaling and polishing and whatever else language we would need around that. The other thing that you're suggesting that the D4910 code encompasses is site-specific re-scaling and root planing, right? And so it's not, so sometimes they'll relapse and only just be 1 or 2 areas, right?
That's right. So if we look at what that descriptor for D4910 says, it states it includes removal of the bacterial plaque and calculus from supragingival and subgingival regions, site-specific scaling and root planing where indicated, and polishing the teeth. If new or recurring periodontal disease appears, additional diagnostic and treatment procedures must be considered. So, and I didn't read the entire descriptor, but that's what I'm talking about, is that information I just read is part of that procedure code. Well, you need to tell me about it in that story, the patient's clinical note.
So when we're working with, like, for example, I still practice hygiene all the time. And in my notes, as a team notes, I should say, we say, was there bleeding upon probing? And was there bleeding upon scaling? And where is it? What are the current and previous risk factors for disease? And we also have a line that says, is the disease stable, improving, or declining? So in addition to those pieces of the story, what do I need to add to my auto notes so that when I'm going in there and telling the story, I'm not missing anything?
I need you to tell me the teeth numbers that you performed that site-specific scaling and root planing in those sites.
So like 2 and 3 is active disease. And so I specifically did active disease for teeth 2 and 3.
Yes. So think of it like this. If you had a patient that came for years and was so compliant and you were maintaining his disease, and then all of a sudden, due to some personal issues, that patient just quit coming, and you made attempts to follow up, but the patient just didn't come in. But all of a sudden, the patient has some issues and goes to another dentist. You could find yourself in a court of law because that patient could be stating he's losing a tooth because you failed to treat his disease on that tooth. Could you defend that in that court of law with your documentation? Because that's what you have. It's not about reimbursement. While I do teach insurance on how to, gain the most reimbursement, it's about ensuring quality patient care. We do that through the story we tell in our clinical note. So that's what you need to ask yourself. Anybody reading that chart note should be able to know the condition of the teeth and the condition you're treating, what you did, the who, what, how, and why. Why is what we don't have, and that's where our specificity comes in.
I like that. And can I ask this, something I remember hearing you say too, to me in previous conversations, was that not only do you need to, it's so important to document that, especially the site-specific, if you've had to add some teeth in that needed something different than just the prophy perio maintenance type procedure, that insurance companies now are, if they see perio maintenance after perio maintenance after perio maintenance, and they ask for chart notes, and they do not see that you've really done anything more than basically a prophy, because the patient has stayed maintained, they could actually turn that around and make it go back to an 1110. Is that correct? Am I saying it right?
Or what they'll do is sometimes they have limitations. If you've had a patient receiving 4910 perio maintenance ongoing, all of a sudden their plan stops paying for it because they have not had scaling and root planing within 24 to 36 months. So they'll stop paying for it. But if you've got this trail of documentation, this historical data, you can appeal that and say, but on such and such date, we performed site-specific scaling and root planing. This was the condition around that too. This is what we did on this date to treat it. And you've got that, and you've got your historical data with your periodontal charting and probings and your x-rays to go along with it.
And the charting of bleeding,
Yeah.
right? That is really
Absolutely.
important.
Okay, but that, so yes. And what about if our patient had previous active periodontal disease and we're maintaining it because the 4910 service that we're providing and the patient's commitment to their own routine is such that that combination is working. And so they don't need site specific and they don't need a rebilling of that 4341 or 4342. But they truly are still in that maintenance phase because, you know, once the periodontal disease is there, we want to maintain the bone and make sure that they're coming in so that we don't have that reoccurrence of disease. What do I do then, Dilaine?
That's a great question. You still need to ask yourself the level of specificity in my documentation for that visit. Does it really, truly describe in detail exactly what I saw? And you just submit that and appeal it. And you state this is ongoing periodontal therapy through their perio maintenance procedures. And on these dates, this was the condition of this patient, and this is what I did to treat it. And you show that, again, that historical data. Are you going to win all of those appeals? No. Again, it's not always about the insurance reimbursement, but it goes back to, can you ever defend that? So it's that, even, you know, for your question, Brandy, it's that level of specificity. And I don't often see what you described in your chart note, unfortunately, when I do chart reviews. I know you guys know.
Well, it's a journey, right? And my chart notes did not start out looking like this. My chart
Oh,
notes
no.
in 2007 when I graduated, I was so proud of them. They were like 3 lines long. And I thought that I would, yeah, and I felt like I was doing a brilliant job. And, you know, my favorite Maya Angelou is do the best you can with what you have. And then when you know better, do better. And so that's why I'm so excited to pick your brain, because when I sit down as a business owner and I'm having these discussions with my patients as a clinician, with my other clinicians as people that have tried really hard to take care of our patients and then had the insurance companies fight back, you start to feel like you're in this soup pot of Melva Hess, and you don't know what to do about it. So I really appreciate that you can take it down to, it's not that we change what we do, it's that we tell the story more completely so that someone else knows what we're doing. So like if I sit down and do your teeth and then in 3 months, Jamie sits down, she can pick up where I left off. So we're not only protecting ourselves legally and from the insurance standpoint, but now we're also making sure that you have continuity of care, even if I don't happen to be available to be your clinician this next time. So I think that's a brilliant guidance for all of us.
Absolutely. And that's what it's about, you know, and a good test with your practices and within your own practice is to start implementing internal audits. Have different team members randomly pull chart notes. Have somebody not associated, maybe a business team member, not a hygienist, not a clinical person, read that chart note. Can that person know and tell you everything that happened and why?
Could they almost envision exactly what happened and why?
Yes.
So it's okay, just for clarity on Brandy's question. So you're talking about a patient that once had periodontitis, and they go through all the procedures, the scaling and root planing, I like to say periotherapy, and they do that, and now we're on this 3-month, regimen, and there's no bleeding, basically, because there's no bleeding. So that's now reduced periodontium.
Right.
So reduced periodontium versus periodontitis, how does that fit together with the 4910 versus an 1110?
That is a great question. Yes. So the code states in the descriptor, the first line, this follows it follows periodontal therapy, active periodontal therapy for the life of the dentition and implants, right? And we all know that. So
that's what you can fight about. That's what you can try to appeal, because it states right there.
Yeah. And my teachings don't change if all of your patients were uninsured, because it goes back to that continuity of care. And we've never in dentistry had to prove the medical necessity, but we do now. It's and we have to show that. And even it's not about insurance.
Right.
It's no different.
Where the risk factors really come in. Like, you need to talk about what else is going on. Was there an elevated blood pressure? Are they taking medications? Is there other inflammatory diseases, et cetera, et cetera? That way, Jamie can pick up where I left off and know how to care well for you, regardless of not being the same hygienist.
Yeah.
We have to establish that link between their medical conditions and their oral health. And what are we doing to treat their oral health that affects their current medical conditions or helps prevent other medical conditions? So that all systemic link, it's there, but we have to establish that link in our documentation. I often read update medical history, see medical history. Do you think that establishes that link? Absolutely not. Tell me more. Tell me the story. And if I can only tell you how many times a week I see that, that's not established in that link. So have you proven and ensured good quality patient care?
So the takeaways I'm getting is, of course, documentation, right? The other one is that we have to be able to prove specificity. And so, that's a tongue twister, let alone trying to get that in writing and documentation, right? So that's what I'm hearing you, is that those two elements have to be present in their documentation, right? That they have to have that. What if, let's just say we're just scratching the surface on this. That's why I knew that I've done this with you before. I mean, we could go into the specificity of 4346, which is, scaling in the presence of gingival inflammation, all that stuff. So we have so much more, but so that people have to wait for us to talk to you again, can you tell us how our viewers and listeners, if they want to get more hands-on and one-on-one training from you, how can they get a hold of you?
Absolutely. You can contact me through my website, which is tidewaterdentalconsulting.com. You can also give me a call, 704-796-0101. I'd love to have a conversation on how we can help up your storytelling game.
That's great. Thank you, Dilaine. Oh my gosh, there's so many questions. And I know I teach software training at EagleSoft, and I'm just like, they say, I only need about an hour of your time. I'm like, oh, you have no idea how much time. Just one question will lead to 100 more. And then we're at 4 hours, 4 days, whatever it is into it. So thank you for taking the time to be with us. And I know Brandy feels the same way about your wealth of knowledge. I call you the guru of dental coding, and you are.
I do love it.
Thank you so much, Dilaine. We appreciate you honoring us with your time and expertise, and we cannot wait to have you back.